Good evening, friends. So today I'll be talking on this topic, ARDS challenges and solutions. So this talk I gave in one of the pulmonology conference recently. So I'll be talking few aspects of this talk. So most of the components of this talk I have given in other videos, like steroids in ARDS, it's covered in another video. Low tidal volume ventilation and ventilatory strategies in ARDS is covered in another video. So in this particular video, I've taken certain areas where there is little bit of an ambiguity so that we have a bit of clarity on what are the challenges we face in ARDS and what may be the possible solutions with regards to the current evidence that is available. So the topics that I would be covering, one of the topic where we need to possibly have little clarity is whether non-invasive ventilation has any role in ARDS. So I'm sure when we ask most of the trainees who are listening to this, they would intuitively say that it is always invasive ventilation is the way, but what is the evidence with regards to non-invasive and whether there is any role? So ARDS now is really looked at as different phenotypes. So we need to recognize that there are certain phenotypes where certain things may be beneficial, and there are certain phenotypes where certain interventions may not be beneficial. So that is the context in which you have to interpret what is being put as a narrative here. Then the second question is modes of invasive mechanical ventilatory support, whether there is any difference with using any of the different modes that are available. Predominantly, if you have to categorize it into volume controlled or pressure controlled, if one is superior over another, and what is the evidence that may be available. So this is an important area where again there is a bit of a non-clarity when we look at it from an upfront, whether high peak versus low PEEP or a normal PEEP. So whether high PEEP has any role in any subgroup of ARDS. So we look into some evidence with regards to that. So these three areas is what I'll focus on. So about proning, I think we have reasonably good evidence now, and we need to prone certain group of ARDS patients. Very briefly on recruitment manuals and take-home message. So the first question we are going to answer is non-invasive versus invasive mechanical ventilation in patient with ARDS. So we all understand, just again to recapture our memories, non-invasive ventilation improves your alveolar ventilation, recruits the alveoli. It also has an additional benefit of reducing the afterload on the LV, which is also useful because many a times we understand that ARDS can have a concomitant cardiac component also, and it helps in stabilizing the chest wall. So this is the way NIV helps in any of the respiratory failure. So the argument is use of non-invasive ventilation in ARDS reduces the need for sedation of the patients. The patient doesn't need to be sedated for them to be on NIV, and it does reduce the risk of them developing ventilator-associated pneumonia. So this is an argument. So when you look at the evidence, so this was a study that came from the French group in 2000. So here they looked at 123 ARDS patients, and non-invasive ventilation had no effect on the intubation rate or the clinical outcomes. So this was one study which said NIV really did not make any difference. So there was another study which said that non-invasive ventilation is something that could be considered for hemodynamically stable patients. And this study is a small study that came from China in 2012, 40 patients. So they compared NIV and HICON, and they found that in NIV patients, PaO2 and FiO2 significantly improved, and intubation rate was significantly less, 4.8% as compared to 36.8% in someone who was getting HICON. Even mortality was less, and even organ failure was significantly less in the group that got NIV. So this was a small Chinese trial that came in 2012. But there were a lot of limitations with this trial. As you see, the sample size is very small, and serious adverse events were underestimated. There was selection bias, and there was no blinding, and they did exclude patients more than 70 years, and they did exclude severe ARDS. So this is something which you need to keep in mind, that here they have taken mild to moderate ARDS. So severe ARDS they had excluded. So which means to say we do not know in severe ARDS whether NIV has any role. So then this was another study which came little more recently from the Italian group. I'm sure most of the listeners would know when the COVID struck Italy, a lot of helmet masks were used. So here in this group of 81 ARDS, they used NIV predominantly or only with helmet mask, and they found there was significant reduction in them needing intubation. So intubation rates were significantly reduced with NIV. And then there was this another trial that came much later after the Italian trial, 83 ARDS from the US group, where it showed the non-invasive ventilation improves survival and reduces the intubation rate. So you saw it is a bit of a yo-yo. So you saw the Chinese trial which showed benefit. Before that, the French trial did not show any benefit. But now the recent trials again are showing that NIB possibly does have some role. And this is possibly due to advancement with regards to the way NIB is being used and different sort of a technical advances that may have happened. So now the question is, how do we recognize which phenotypes NIV will help? So there are two studies to see how we determine that NIV is being helpful to the ARDS patient and how to determine that the group of patients who are failing NIV. So that came from this particular study. So this was a prospective observational trial where they looked at 101 patients. They looked at rapid shallow breathing index as an index of NIV success or failure. So I'm sure most of our listeners would know RSBI, which is used as a weaning index. So if so RSBI is respiratory rate divided by tidal volume. So if RSBI is more than 105 beats per minute, then it is an indication that possibly patient is failing NIV and they need to be intubated. So this gave some direction or that NIV could be tried. And if patient is failing with an objective measure of the RSBI, then go ahead and intubate. At least we have that sort of a direction as to determine who is winning on NIV and who is not winning. There is another index which came from the French group, which came again from prospective observational trial in 62 patients, where they said anyone who's generating a huge tidal volume of more than 9.5 ml per kg per body weight, who's tachypneic, generating huge tidal volume, it is an indication of NIV failure and they need intubation. So we clearly understand there is a entity called SILI, self-inflicted lung injury. And if someone is generating such high tidal volume, so there is a perpetuating of the ARDS and further worsening. And these are the patients possibly who need to be intubated and ventilated. And maybe they may need muscle relaxation also the initial phase so that we reduce this perpetuation of the self-inflicted lung injury. So we have two indices now, which could be utilized to see who is responding well to the NIV and who is not and who will need intubation and ventilation. So the solution, so the answer, whether NIV should be used, NIV in many of them, so with the available evidence, could be used in early phase of the ARDS. And once you use, you have to determine whether patient is responding well or whether he is failing with NIV. Obviously, if they're failing with rapid shallow breathing index more than 105 or there is evidence of self-inflicted lung injury, then go ahead and intubate. So that's the answer that we can subscribe to at this point of time. So now we'll move to the next challenge in ARDS, which mode of ventilation, whether any mode will make any difference. So there are certain arguments that volume controlled ventilation gives a better measure of respiratory mechanics. And with regards to volume controlled, you have a better way of measuring driving pressure, which is P plat, plateau pressure minus P. And volume controlled ventilation is claimed to reduce the occurrence of villi if it is delivered in the right way. And there is a guaranteed tidal volume, which is a benefit. So, on the contrary, pressure controlled ventilation is claimed to be superior because of the decelerating waveform. But when you look at the studies, volume controlled versus pressure controlled, none of the studies have shown any major difference. So, what is the evidence for this? So, one evidence is a big meta-analysis that came from the French and the Thailand group. They looked at 34 studies comparing different volume control and pressure control. It did not show any difference in the clinical outcomes. But although the studies criticized as these small 34 studies which were included for this were very small and had a varied quality. So as of now, the solution for this question or a challenge that which mode, so either mode you can use, but most of the clinical studies are done with volume controlled ventilation. So there is sort of a leaning towards usage of volume control. Pressure control is something that one could use in certain specific subgroup of patients, especially when there is a barotrauma or bronchopleural fistula, so on and so forth. In that situation, one could consider, but with regards to evidence, there's no difference with either of these modes. So that's an answer for that. So the strategy for ARDS, the so I won't be talking about low tidal volume because all of us are very clear with regards to low tidal volume and plateau pressure less than 30 is what we should maintain. And there is the robust evidence and it has a good levels of recommendation. I'll only talk about the PEEP. So the strategy in ARDS is minimizing the airway pressure, some permissive hypercapnia, which is needed for alveolar recruitment. And we do accept permissive hypercapnia, which causes good alveolar recruitment. And our intent is to prevent overdistension of the alveoli and hyperperfusion of this pulmonary circulation. And that is the main strategy that we need to adopt, and which encompasses the principles of protective lung ventilation. So high PEEP is claimed to improve oxygen. So we all know that you give high PEEP, it improves, but we are very unsure whether it has any bearing on mortality, whether it reduces mortality, we are not sure. So why do we give high PEEP? So because we understand in ARDS, the alveoli or the lungs, there is a huge amount of heterogeneity. There are areas of lung which are over distended. There are areas of lung which are normally distended, and there are areas which are atelectatic. So with PEEP of 5, if alveoli look atelectatic, so we give high PEEP. Our hypothesis or intent is to recruit this alveoli and improve the oxygenation. So this is our hypothetical understanding as to why we use high PEEP. And as I said, our hypothesis is high PEEP influences clinical outcome. And we do understand ARDS lungs are hugely heterogeneous. There are different areas of the lung, some areas which are atelectatic, some which are distended, some are over distended. So with regards to high PEEP, so we need to understand because of its heterogeneity, there are certain areas of the lungs which are recruitable. There are certain areas of the lung which are non-recruitable. In the areas of lung which are recruitable, high PEEP is shown to be beneficial. In the areas of the lungs which are non-recruitable, so if you have a lung with non-recruitable alveoli, you give high PEEP, it can be detrimental. It can lead to deleterious effects. So let us look into the landmark trials, which have looked at comparing high PEEP and low PEEP, and all trainees should know at least the names of these trials. The first trial that came, all these trials came at around 2006 to 2008. So if you look at this first trial, which came in 2004 by the US group, alveoli trial, they looked at 549 patients with ARDS comparing high PEEP versus low PEEP. After this alveoli trial, there was this Canadian trial called the Laos trial, which came, which looked at the bigger number of patients, 983 patients. Then there was this Express trial that came from the French group in 2008. As you see, these trials are between 2004 to 2008. All these three trials compared high PEEP versus low PEEP. And what all these three trials showed was high PEEP definitely improved oxygenation. But high PEEP did not show reduction in mortality. So alveoli trial, Express trial, and Laos trial, all these three trials failed to show that high PEEP has a bearing on reducing the mortality. So that is where our enthusiasm was tempered that whether high PEEP really helps. After this, there's a beautiful meta-analysis that came from the Canadian group, which again tilted the pendulum to say high PEEP has benefit in select subgroup of patients. And what is that subgroup? So that came from this beautiful study. This was published in 2007. As I said, all those three studies were between 2004 to 8. This came in 2010, which is a meta-analysis of 2,299 patients comparing high PEEP and low PEEP. And this came in JAMA by Braille et al. So when you look at ICU mortality, it was significantly less in high PEEP group. Hospital mortality, there was no difference. And expectedly, oxygenation significantly improved in high PEEP group. Ventilatory free days, which means duration of ventilation was less. Ventilatory free days was more in high PEEP. And the need for rescue treatment was less. So this gave again a it shifted the pendulum and gave a signal towards the benefit of using high PEEP. But what this study showed in subgroup analysis is that high PEEP was beneficial in group of patients with PaO2 by FiO2 less than 200. And the study also showed signal towards being detrimental if you give high PEEP in patients who have PaO2 by FiO2 more than 200, which means, again, we are trying to identify and recognize the phenotype of the patients where high PEEP is beneficial. You do not give high PEEP for every ARDS. You only give high PEEP to patients with ARDS or a phenotype of ARDS where PaO2 FiO2 is less than 200 and it was shown to be beneficial. After this, there was another meta-analysis, which is the mother of all meta-analysis, Cochrane review by the Argentine group, which came in 2013. This was again done in meta-analysis with 2,565 patients. As you see, hospital mortality, there was no difference between high PEEP and low PEEP. And expectedly, like all the studies have shown, oxygenation significantly improved in high PEEP. And the mean difference of oxygen improvement was 41 millimeter mercury. Ventilatory free days, which was better in the Canadian meta-analysis, there was no difference in this. But again, in this Argentinian meta-analysis or the Cochrane review database, in subgroup of patients, PaO2 by FiO2 less than 200, ICU mortality was significantly reduced, and that attained statistical significance. So there were two good meta-analyses which showed strong signal that in phenotype of ARDS, where PaO2 FiO2 is less than 200, high PEEP was found to be beneficial. So the conclusion they made was high PEEP in moderate to severe ARDS improves oxygenation and reduces mortality. So is there any other way we identify the phenotype? The other way we identify is the driving pressure, which we have understood. Driving pressure is P flat minus PEEP. And for all the trainees, you need to understand why driving pressure is important, because driving pressure helps to identify the phenotype of the patients who have recruitable alveoli where PEEP can be increased, and that would show direct correlation to reduced mortality. So this is what is important. So what do we understand? If P flat is rising, so if plateau pressure is going up, you obviously reduce the tidal volume, but you do not optimize the PEEP. So delta pressure, which is the driving pressure, is P flat minus PEEP. So your P flat is increasing and you have not optimized the PEEP. So your driving pressure rises, so your mortality increases. This is very important. Just pay few seconds to understand this, which I've spoken in few other videos also. If P flat is going up, which obviously the only maneuver you can do is reduce the tidal volume, and you increase the PEEP. So then you optimize the PEEP. Then the driving pressure is P flat minus PEEP. So P flat is going up, PEEP you are trying to optimize, but driving pressure remains the same because both are rising. Then mortality remains the same. So these you are able to recognize, prognosticate, and identify the phenotype of patients who is responding to your PEEP, and which is helping you to determine whether they have recruitable alveoli or not. If they're recruitable and they're responding, you have ability to increase the PEEP and you have an ability to reduce the mortality. Then the third is category, which is important for us, is where P flat is not going up and you are optimizing the PEEP. You are increasing the PEEP because you know there is recruitable alveoli. Then your driving pressure starts falling. So you want driving pressure to be less than 15. So P flat is say 30 and PEEP you have increased to say 16 or 18. So then your driving pressure is less and your mortality comes down. So this is the way we have tried to understand the correlation of P flat, PEEP and driving pressure, and trying to recognize the group of patients which have recruitable alveoli where you are able to recruit with increasing in the PEEP, and by increasing the PEEP you are able to reduce the driving pressure, and by reducing the driving pressure it has been clearly shown if your efforts are able to reduce the driving pressure, you are able to reduce the mortality. If your efforts are not able to reduce the driving pressure, if it is same, then the mortality remains the same. But if despite all your efforts, if your driving pressures are going up, then your mortality is high. So this is a group of patients, possibly one should move to ECMO because your PEEP strategy is failing. And maybe and by now you would have obviously proned also. If that is also not functioning, I think that is the stage you have to think of the alternative. So this is a very important slide. And in exams, if they ask, please write this table. It's very simple table. And this pretty much encompasses the ethos of our PEEP management and trying to recognize the phenotypes which are responsive to PEEP and how it has a correlation with mortality. So the solution is driving pressure best stratifies the risk in patients with ARDS, and the concept of protective lung ventilation is to direct the amount of PEEP that the lung can take or that the lung needs, and the amount of tidal volume that lung needs. So you are only targeting this PEEP and lung to the functional size of the lung. When I say functional size, it is the lungs which is responsive to your PEEP, and the lungs which need the amount of tidal volume that is just about enough. That's what it means. And the clearly, if your efforts are able to bring down the driving pressure, then the survival can be improved. So open lung ventilation is nothing but low tidal volume with PEEP, and a high PEEP with maybe recruitment maneuver as a salvage measure is useful, especially in moderate to severe ARDS. So those are the challenges, and this is the solution for that. So so that's what I wanted to focus more in this talk. So about prone ventilation, it is fairly clear. We had a Proseva trial. So prone for 16 hours is what is found to be beneficial. And in any patient who is intubated mechanical with ARDS in less than 36 hours, if they have severe ARDS with PF ratio of less than 150, on FiO2 more than 60% plus PEEP of more than 5 with protective lung ventilation with tidal volume of 6 ml per kg. If things are not getting better, so they do deserve to be proned. And prone ventilation has shown, this particular study showed reduction in 28-day mortality and 90-day mortality with good proning for 16 hours, especially in this severe ARDS. So just before this, there was a meta-analysis which showed signal towards this direction. So this was a meta-analysis which came from the Canadian group, and where the proning, especially in a sick ARDS with PO to FiO2 less than 100, had shown reduction in the mortality. So just for all our trainees to recapture their memories, so there are certain contraindications for prone. So if someone has an ICP more than 30, traumatic brain injury, someone having hemoptysis, or someone having a neck instability, post-surgical cases like post-abdominal surgery cases, or so on and so forth, someone who has arrhythmias, or post-cardiac surgeries, or hemodynamically unstable, these all can be the contraindication. And there needs to be a lot of logistic help with regards to proning. So obviously you need to have cushions at the pressure points, and frequent change in positions may be needed. And you need to have at least 4 to 5 nursing staff and physiotherapists to do proning. And there are certain complications in proning. You can have conjunctival sort of a congestion or swelling around the eyes. There can be a lot of purulent secretions, and there can be migration of the ET tube or displacement of the lines or migration of the Riles tube, so on and so forth. So these are some of the technical challenges and complications in proning. And hypoxemia sets in proning. It can be difficult, and there can be reduction in the chest wall compliance, and one has to use neuromuscular blockers when someone is prone, and if they have arrhythmias, that also can be problematic when they are prone. So these are some of the intuitive problems that one could face. So quickly I'll talk a little on recruitment menus. So obviously when you have done low tidal volume ventilation, optimized the PEEP, and you have proned effectively, and you've used neuromuscular blockers, so on and so forth, still patient is hypoxemic, then as a salvage measure, recruitment maneuvers are done where you increase the PEEP to 35 to 40 centimeters of water for around 40 seconds. And there are studies have shown, so this is again a meta-analysis published by Australian group, which showed the recruitment maneuvers improve oxygen, but it did not have effect on mortality, length of stay, or barotrauma. So, and we do not have consensus whether 35 to 40 PEEP is good enough, or 30 to 40 is good, or 40 to 50 is good, for how long we need to give this PEEP, and how frequently we need to give. So there are no clear sort of a direction with regards to this. But for all the trainees, you can keep this number 35 to 40 for 40 seconds is what has been used in few trials. So that is something you can keep in mind. And one also needs to bear in mind, this recruitment maneuvers is not free of complications. It can have lot of hemodynamic because you're increasing PEEP to supranormal levels. So there can be hemodynamic instability, and they can have barotrauma, so on and so forth. Sigh breath is where cyclical PEEP is given every 3 to 4 minutes, again at a very high level of 45 centimeters of water. So these are some of the recruitment measures which is used as a salvage when there is sudden hypoxemia in ARDS patients and you need to gain control of the respiratory status. One could consider this. By then you would be possibly thinking of ECMO and so on and so forth. This is a pictorial representation what happens in the recruitment in the pig lungs. And this is a good slide where again you see most of the de-recruitment and the atelectasis is happened at the bases. So with recruitment maneuver, you tend to open up the alveoli. But what happens? What can happen to another extreme in recruitment is if you try to open up all alveoli, so then there can be over distension of the already distended alveoli, which leads to barotrauma. So we do not know what sort of a recruitment PEEP is safe for any lung. So this is what is the problem with recruitment, and that's why it improves oxygen, but it can lead to deleterious effects. And just for all the trainees, when you're doing recruitment maneuver, two people should be at the bedside to monitor patient and ventilator. Patient should be adequately sedated. Patient should be connected to monitor, standard sort of a monitor, and one should have an eye on the monitor. And one should look at the airway pressures and the compliance before you do the recruitment. Post recruitment, and always an IV fluid line has to be connected for resuscitation when there is hemodynamic instability. Adrenaline has to be kept, vasopressors has to be kept, crash cart has to be kept before you do the recruitment maneuver. And to determine and ascertain if recruitment is successful, you need to have improvement in the oxygenation, improvement in the ventilation, and there should be improvement in the compliance. So these are the measures to indicate that your recruitment has been successful and has helped the patient. So the take-home message for some of the challenges. NIV, yes, it has a role in certain subgroup of ARDS, especially in the early ARDS, but the quintessence is to recognize the patient if he is responding to ARDS. Look at the rapid shallow breathing index, which is a simple tool. If it is obviously less than 105, then patient is getting better on NIV. But if it is more than that, then you may have to consider intubation. Or if someone is generating huge tidal volumes, then there is a perpetuation of your CILI, which is not going to get patient better. So you may have to intubate these patients. So volume controlled versus pressure controlled, there is no difference. And I've spoken enough about high PEEP and driving pressure. So focus on driving pressure, keep it less than 15, try to optimize PEEP. And that is the good indicator of determining which patients have a better survival. And we did speak about all this. If you are able to bring down the driving pressure, it indicates to you that patient is going to survive with your good ventilatory strategies, and you don't need to jump to ECMO. And prone ventilation is needed in severe ARDS where PaO to FiO2 is less than 150 to 200 with a FiO2 more than 60% and with adequate PEEP. So that would be the summary of these particular challenges that we face with ARDS. I request all my listeners to submit their valuable work to Journal of Acute Care, which comes out every 3 months. So you can submit any pictorial CME, video CME, case reports, case series, so on and so forth. So we invite all our trainees to publish their valuable work. So you can visit my website, www.drpradeeprangappa.com to read to this lecture. So thank you one and all.